So let's go and talk about bones themselves. So always, if you want to chunk it up and break it up into those types of bite-sized pieces, it can help you think through the problem. Now, majority of the time, bones and ligaments, we can talk about fractures, we can talk about those dislocations, but majority of the time, your severe cases, your complex cases are going to be in your fracture dislocations. And then you always want to think, well, if I have something severe, then what are the complexities? Where are the problems going to lie? And majority of it's going to be in the fact that, is it stable? Because it might not be stable. We might have to do certain things to stabilize it. And when we stabilize it, it might affect our mobility and range of motion. And if that's the case, so what are we going to do about it? And the nerves, you know, we have to think about all the different nerves that pass through. So let's talk about bones. And we're just gonna break it up. And this essentially, I looked at the 6th edition and 7th edition. I really didn't see any major differences when it came to this particular section. And the chapters are a little bit different, but is essentially some of chapter 3, which is like the anatomy and biomechanics and blah blah blah, and then the other chapters, which is like surgical intervention and blah blah blah, and therapist intervention. So I'm taking all of those pieces of information, I'm just chunking it up for you guys. So we'll talk about bones. So there's 3 bones. That's how my brain works. I said 3, so I had to write 3. So there are 3 bones, and we know that in terms of bones, the medial and the lateral epicondyles are attachment points for ligaments and muscles, right? And the trachea and the humerus, the way it meets, it's 6 to 8 valgus angle. There's an anterior portion of the sigmoid notch where it meets the coronoid and adds stability to the elbow. 80% of the olecranon can be removed and still have stability if there's soft tissue and the coronoid is intact. That's a key concept that comes from chapter the anatomy. Like you can have a fracture of the olecranon and remove a certain part of it and you can still have stability as long as the soft tissue is intact and the coronoid is intact. So how and why is that important is when there's a really bad comminuted olecranon fracture, you can remove that back part, right? That's this point of your elbow. You can remove that back part. You can't remove the front part. So if the front is bad, then you have to fix the whole thing. And that's what I mean by, you can remove 80% of the olecranon, right? So that was another key thing. The radial head is also the secondary stabilizer. What else? That was coming from, that was coming from chapter 3. So let's go over into the fractures. So when there's fractures, then we just know that we need to get stability first, right? So there's different types of fractures, but really the goal of any type of fracture is to realign and stabilize that fracture. And then especially in the elbow, they encourage definitely early controlled motion, especially with an ORIF. You can have an ORIF. Very rarely they will have a K-wire with traction, but majority of the time they're going to have, an ORIF. There have been people I've seen, I think they do talk about it in the chapters where they do, it's RIF because it's still open, and they can't always plate the olecranon, so they'll pin it, and then like K-wire, and then those will eventually come off. If there's a step off or malalignment of the greater than 1 to 2 millimeters, it can create elbow joint dysfunction. So if there's a 1 to 2 millimeter step off, so the goal of surgery is alignment and stability, right? There's RIF, there's plates and screws, and then of course, if the fracture is really bad, they could do a total elbow arthroplasty. And usually a total elbow is going to be reserved for someone who's older and with low functional demands, right? So let's take a look at the potential fractures that could happen. So you can have a distal humerus fracture, right? You can have a olecranon fracture, and then of course you can have your radial head. So olecranon is going to be your ulna, this is your radius, and then your distal humerus is going to be your patellum and trochlea, right? So that's essentially your distal humerus. So I'm not going to go into, you know, way too much detail in terms of these fractures and what they do and where they are. But just know, like, that's how I like to group them, is distal humerus, olecranon, and radial head. Now, majority of the time, you're breaking your distal humerus and your olecranon, you're going to need surgery. Majority of the time. But obviously, it really depends. If there's no displacement and all that good stuff, you can stabilize it and you can immobilize it for a short period of time, and then you can start to move it, right? As long as it's a simple fracture. Majority of the time, these types of injuries are falls in a very particular way on an outstretched hand, and the force gets applied there, or there's different accidents and they get hit on the side or anything like that. You're going to see these types of fracture. Radial head fracture, for sure, it's an outstretched hand, and you can have small fractures where they'll just immobilize you for like a week or two, and then all the way to like shattering it so bad that you need a radial head replacement, right? But either way, let's take a look at what we would want to think about when it comes to the recovery. So if you take a look at this chapter, and I believe it's, oh, I didn't write down which chapter it was, but it's basically going over, and it really groups them up as like fractures, right? So when it comes to fractures of any of these, as long as you had surgery, K-wires, you know, which is not necessarily the best in this case, or they'll do ORIFs, plates and screws, right? Once they are relatively stabilized by the surgeon and stuff like that, then we're going to go into our protocol. Ideally, therapy is going to start, there's two phases. You have the post-op phase, which is really 0 to 3 weeks. And a lot of the new protocols, especially in the 7th edition, they're really saying you want to start 3 to 5 days. Essentially, in the first week, you want them to go into therapy, and you want to start a controlled motion protocol. Now, I think majority of the time, all of therapy post-surgery is going to be, they're moving towards early motion and stuff like that. This is especially true in elbows. This is especially true in elbows. We need to get them moving and get them moving fast, because the key #1 complication out of an elbow injury is post-traumatic stiffness. The stiffness and the tightness and all that good stuff develops into a contracture. The contracture leads you into, like, you know, trying to be more aggressive and stuff like that, and then start to think about what are some of the issues that you're just going to end up. If you have stiffness, what's happening? Is it the capsule itself? Could it be heterotrophic ossification, you know, after a type of injury, right? If you have heterotrophic ossification, then, you know, what happens? You can't move it. They become really stiff. They're not functional and all that good stuff. They don't get that functional range that you're looking for. So then what happens? You know, it becomes a cascade, and I often talk about cascades of injuries. It becomes a cascade of an injury where if you can't get the motion, their wrist starts to go, their shoulders starts to get messed up, and then they need another surgery to fix the capsule tightness, right? And so it is, it's really important to make sure that these people start moving right away. And this controlled motion protocol, they're essentially talking about gravity eliminated wrist motion, elbow motion. right? They're talking about gravity eliminated elbow flexion extension. You cannot be too aggressive. So if you take a look at the chapter and what it's telling you in terms of gravity eliminated motion, they're calling it controlled motion. They're using a couple of different words, but essentially gravity, using gravity eliminate. But basically you're in supine, and you want, if you're reading that chapter on what the therapist does, they're basically in supine, shoulder is at 90 degrees, and with the use of gravity and the weight of the arm, they are bringing the hand down to the head, the nose, the mouth, the ear, right? And so it's getting you elbow flexion, but without being aggressive. And then basically you can then drop your arm down and then bring your arm into gravity limit tricep extension, right? It's the easiest way to move the elbow without being aggressive, right? So no aggressive motion due to the risk of HO. CPMs have not shown any positive effect on range of motion. I say that CPMs have not shown positive effect on motion. Now, one thing that I did notice that this chapter said that, and then in the therapist chapter said that after a capsulectomy to use CPM. So I'm just telling you the discrepancy so that you understand, like, you know, if the questions confuse you, just think through what the story might be, right? So CPMs, ideally at the beginning and the post-op, they're not showing its effectiveness, right? But CPM potentially after a capsulectomy due to post-op stiffness can prove to be beneficial, right? 2 chapters, 2 different authors. I'm just letting you know the little discrepancy. So if you were to run into something, it's not that they're wrong or anything. It's just like the perspective and how to think about it, right? So so that's what you do essentially at the beginning. You want to always think about what are the potential complications, right? So complications, we are going to potentially have the edema, pain, stiffness, nerve compressions, right? So now it all depends essentially on what might be the issue here of compression. You might experience some infection issues, especially with hardware. What else? You might experience malunion, non-union, and then you want to know potentially, you know, what to look for essentially. You can have any of all of these fractures. I have a guy, he's a truck driver, and his arm was hanging outside while he was driving. And something happened, and his he took a curve or something, he was turning or something. I don't know what happened. The truck flipped over and he landed on his arm, completely shattered his elbow, lost a ton of, you know, tissue, there's bone issues and stuff like that. And he had like so much, he went somewhere else and had so much therapy. But they essentially ended up fusing his arm, right? But these are essentially all the complications that he had. I mean, he had literally every single one of them before he came to us. You know, they tried to plate him, they had to graft his skin. He had a previous ulnar nerve injury there, but didn't have any problems with it. And then with this type of elbow injury, it got worse. He ended up developing, he had a malunion, non-union type of issue, and then he got infection because his skin was so tight, and with the graft and stuff like that, he just had this one spot that would not heal. And so they took out all his hardware and stuff like that, and they ended up still leaving like 2 screws in or something like that, and he had this one spot that just constantly would open up, and like have a little bit of drainage or whatever, but it's like also like the spot where he didn't have like the muscle, you know, he just had like a lot of skin. So you know, just think about if you couldn't bend. So he was fused, they ended up being fused at like about 30 degrees, right? So he can't bring his hand to his mouth. He can extend, like his arm is an extension always, so he can reach like this. So what are his potential problems in the future? But he had no supination and no pronation. And to keep him as functional as possible, when they fuse him, they're not going to fuse him necessarily in neutral. I don't think they had a choice, to be honest with you. So they fused him in pronation. So this is him. He can never turn his palm. He's limited in his grasp. And because of all the tissue loss, it actually doesn't have enough wrist extension, right? So, so anyway, because you know about all these potential problems, you're gonna know just what essentially to look for. Always pay attention to history. Always observe, palpate, note the carrying angle that they have, because the carrying angle is going to help you identify some potential problems, right? Look at edema, look at pain. And so how to identify some of these complications. So from 0 to 3 weeks, you have protective. So you're starting essentially at 1 to 5 days post-op, right? You have an orthosis. You have an orthosis at 90 degrees. Now the forearm, supination, pronation, or neutral are going to depend on ligament stability. You're going to work on edema, pain management, patient education, gravity, doing the gravity eliminated flexion extension, and watch out for the drop sign, right? So the drop sign is the distance of the trachea and the olecranon. When it's greater than 4 millimeters on a lateral x-ray, it can lead to ulnohumeral impingement, right? Which then can lead to stiffness and arthritis. So that's one of the complications, a drop sign. Now the drop sign is noted on x-ray, right? So if you have access to x-ray or talking with the surgeon, but that's essentially one of the things that you're going to be looking for, especially early on. You're trying to do the controlled motion so that you can decrease that risk of a drop sign. You're looking for range of motion of all other joints, right? You're going to then start to increase early controlled motion without the risk of elbow stability. So we'll talk in a little bit more about ligaments, and then we'll go into forearm position and like stability issues with that, right? But that's essentially the first phase. And then the mobilization phase, right, is 3 to 8 weeks. So this is the mobilization phase. Right. So here, see how fast it moves, 0 to 3 and 3 to 8. You already start to increase range of motion, promote tissue extensibility. You're going to progressive from active into passive. So at the very beginning, you're not doing any passive, you're just doing active. And then as you progress, you're going to progress from active into passive. This is where you potentially can test out the biceps, stretch it out, work on shoulder and elbow extension, work on isometrics first before you then start to move towards progressive resistive exercises, right? Your goal is to restore motion and maintain stability of the elbow. And then as you start to increase active, passive range of motion, isometrics and stuff like that, and general strengthening, then you'll start to introduce proprioceptive strengthening and then total arm strengthening. So it's really just like the 2 phases, but the mobilization phase goes relatively fast. Obviously, it's all due to stability of the fracture, right? And then of course, when we start talking about fracture and ligament issues, then that's another issue.